Hello everyone and welcome to Real Health. I'm Michael Porter and thank you as always for joining us for the show. Now in the past couple of episodes we've been exploring issues pertaining to men's sexual health. So today we're going to be shifting our attention to women's health as we put the focus on the causes of sexual dysfunction in females. And joining me in the studio for this discussion is Sister Elise and Dr. Mark from the T Clinic. Welcome to both of you.
Thank you.
Now, in terms of sexual dysfunction in men and sexual dysfunction in women, I mean, it's not one and the same, certainly, different parts, different issues. So what are the main things that we're looking at in terms of women in sexual dysfunction?
Michael, I think when we look at the causes of sexual dysfunction, they're quite similar. But because a woman's sexual response is completely different to that of a man, a woman has a linear sexual response. So she moves through her sexual response phases in a linear fashion, where men have a peak and then a resolution.
Okay.
So the problem that we have with women's sexual dysfunction is that they overlap, the different areas overlap with one another,
Right.
because it's a straight line and not a curve.
Okay. Elise, let's just unpack that a little bit more, the concept of this linear system, if we want to call it that.
Yeah. So interest, desire, arousal, orgasm, resolution all works in one line for
Okay.
a woman. So that's why it's difficult to differentiate. This woman has an interest problem or an
Right.
orgasm problem or whatever the issue is. It's very important that we differentiate where the dysfunction is prevalent.
Okay.
And that's the difficult part for women.
Right.
Yeah, the problem with women is because of this linear line, you can have more than one type of sexual dysfunction.
Yeah, that's also
So
true.
if we look at the types of sexual dysfunction, you have your interest and arousal disorders. Now, the causes of that can be multiple. It can be that it's a hormonal problem as we start going through our perimenopause, menopausal period, where we have a drop in testosterone and estrogen levels. It can be medication that the patient is taking either for blood pressure or hypertension or diabetes. It can be other chronic condition like kidney problems, cancer, liver problems, psychological depression, anxiety. So those are your interest disorders. When it comes to the arousal disorders, it's more patients who cannot get physically aroused. Now, Elise can explain to you exactly what happens when a woman gets aroused. Just like men get an erection, the same kind of principle works for women. Am I right?
Yeah, and I think what we need to understand that our anatomy is basically the same, even though it's an inverted anatomy from men.
But the elements are all
The elements is all the
Exactly.
same. So what needs to happen is there needs to be stimulation. When stimulation happens, there's blood flow to the genitalia, and then you get engorged labia as well as the clitoris, and that's where the physical response is coming in.
Okay.
And with further stimulation, the orgasm happens.
Yes.
Yeah.
So
We tend to forget about patients with neurological damage, patients who had trauma in an accident, who are paraplegic and quadriplegic. These people can still be sexually active.
yeah.
We also need to take or keep in consideration patients who had pelvic surgery or treatment for cancers in that area, had radiation. So, but that will lead to an arousal disorder
Right.
specifically. We can take a look at orgasmic disorders and specifically anorgasmia. Elise, you mentioned the statistics,
it's
something like
very
30%
interesting.
of women.
10 to 15% of women will have through their lifetime, an orgasmic disorder. And then it rises to 30% as soon as they reach menopausal
Okay.
stages. And then 2% of women have never had vaginal penetration because of pain and
So let's talk about that side of things. What is the cause of that? Where does that stem from?
well, that's also quite a few things.
Yeah, so Michael, the most common one that we see is something like a problem with the bladder where we have a cystitis,
Okay.
where with penetration the bladder is irritated.
Right.
We need to think about your endometriosis condition, where you have basically endometrial tissue sitting on the outside of the uterus that responds to hormonal changes, and when you touch that, it's uncomfortable.
Okay.
Any woman with endometriosis will tell you that the abdominal pain, the back pain, the pelvic pain that they have is severe. Your infective conditions, any kind of sexually transmitted disease, pelvic inflammatory disease, you cannot get close to that woman.
Okay.
We have other conditions that become painful, and here we're specifically looking at vaginal conditions. I think the most common one is vaginal dryness.
Yes.
As women start moving through their reproductive years into perimenopause and menopause, because it's dry, it really is uncomfortable. Then we have conditions like vaginism or lichen sclerosis or lichen planus, where you literally, with vaginism, the muscles of the vaginal wall and the labia literally go into spasm.
Okay. So now we've spoken before the psychological side of things, because people don't want to talk about these things. How do you encourage people sort of gently to have these discussions without them being fearful, because it's a very personal thing?
I think platforms like these, where you actually start talking about them. Yesterday we did a podcast on the T-Health show around sexual dysfunction, and it's a taboo to talk about sex, and a taboo is something that you cannot mention. And that's a problem. The moment that you start talking about it and you shed light on it, you take the evil or the bad side out of it.
Yes.
So number one, as we said right from the start, communication about sexual issues in your relationship is key. If something is not nice, you have to voice it.
Right.
If something is not working, voice it, discuss it with your partner. I want to say that if your partner doesn't understand, you shouldn't be your partner in any case.
Yeah.
And then, you know what, find a practitioner that you trust. If you go to your GP starts knowing you. These are things that we as medical practitioners are trained to acknowledge. So talking about it, there is help as long as you reach out.
Yeah.
Sex is such a fundamental part of any relationship.
So Lisa, I just want to go back to the linear sort of discussion, because there's linear in terms of the actual process of sexual intercourse from start to finish.
Correct.
But then there's also this sort of linearity in how these things potentially compound. So if I've got one issue that's causing some kind of sexual dysfunction, might not be huge, but there's something. How does that potentially lead to a compounding effect, which ultimately becomes a really big deal to unpack, rather than dealing with the smaller issues as they happen?
I agree with you, and I think because it's linear, like you say, it's going to impact the next stage of the sexual response. And if you are not interested or don't have a desire, you can't progress to the next phase.
Yes.
And you need to, I want to go back to the response or the human part of intercourse or sex. If you don't know yourself, and if it doesn't go about you or I, then you already have a problem. Because
Right.
how are you going to communicate if you don't know who and what works for you? How are you going to have an interest? Because remember, with interest is, Michael is attractive. Okay. And then next step is there's a physical response, which is
Yes.
desire and arousal. If you can't get that interest part ready, or we call it also libido, lust.
Right.
Lust in the old days was known as vigor for life.
Yeah.
That's not
In fact-
lust in the bad sense of the word.
Yes.
That's what interest is about. So yes, I think it starts with, if I don't have interest, then it's an emotional or a psychological problem already.
An orgasm for a woman is a learned experience. It doesn't happen by itself.
Okay.
women need to explore. They need to know what feels good and what doesn't. And take the guy by the ears and lead him around. You know what? That's what it's about. It should be an enjoyable experience for you, because if you're trying to please your partner the whole time, you're going to create a negative connotation
and potentially resentment towards
absolutely.
the partner. So, Mark, in terms of we've discussed various issues here, are they generally treatable?
Yes, absolutely. It's about getting to the right diagnosis. In other words, understanding the original cause.
Right.
And once you are there, you know where you want to go, you know where you are, now you can plan a route. So there's different treatment modalities that we have available. I think we'll go into most of them in a little bit more detail in one of our next episodes. But yes, absolutely, it's treatable, it's reversible, as long as you are willing to discuss this openly with your partner and with your healthcare provider.
Right. So, Mark, if somebody is sort of seeing the light in terms of listening to this discussion and realizing, sure, I can do something, I need to do something, where can they get hold of you for some more information?
We're here in Johannesburg. We treat patients all over the country and actually all over the world. Easiest is call us on 010-824-1393. Otherwise, you'll find us on your social media platforms and our website, www.tclinic.com.
Lovely. Mark, Elise, look forward to having you back next week, where we will unpack the treatment modalities and get a better understanding of those. So thank you so much for today's discussion.
Thank you.
Thanks, Michael.